Okay, so it's 2 p.m. on the Eastern Coast, so we'll get started. So thank you everyone so much for joining our third Genetics Policy Hub webinar on direct-to-consumer genetic testing. So as we get started, just a couple of housekeeping things. So everyone will be muted as we go through our presentation. But please feel free to chat us any questions or thoughts you have along the way so we don't miss them, as we will have a question and answer session at the end of the presentation. Okay, so to get started, we are very excited to be sharing, as I said, the third Genetics Policy Hub webinar on the topic of direct-to-consumer genetic testing with you all today. So thank you again for joining. Just some introductions. My name is Molly Case, and I am the project manager for the National Coordinating Center for the Regional Genetics Networks. And we are thrilled to be co-presenting this webinar with Dr. Wynn Park. So I'll give her a moment to introduce herself.
Hey everyone, as Molly said, my name is Wynn Park, and I was a former NHGRI and ACMG Genomic Medicine Program Management Fellow and helped with editing and writing some pieces of the Genetic Policy Hub, as well as being a member of the INCC PEG Direct-to-Consumer Genetic Testing Working Group. I'm also the president and founder of the Society of PAs in Genetics and Genomics. So thank you so much for asking me to co-present with you, and I look forward to hearing everybody's questions.
Great, thank you so much. And this project is supported by the Health Resources and Services Administration, and we're very thankful for their support. All right, so to kick us off, here are some of our learning objectives for today's webinar. So we are looking to describe the importance of and identify current policies related to direct-to-consumer genetic testing. So we will accomplish those learning objectives really by providing more information about the basics of direct-to-consumer genetic testing. So we'll provide a definition, describe what it is, talk about its benefits and limitations, we discuss why it's a policy concern. And we'll talk also more about what information related to direct-to-consumer genetic testing can be found in our Genetics Policy Hub. And we'll hear from Wynn Park, about more of a provider perspective to really provide us more of an in-depth background on direct-to-consumer genetic testing. And then at the end, we will hold a question and answer session. So to kick us off, we just wanted to provide a general definition of direct-to-consumer genetic testing. So you've probably heard of some of the more popular testing that's currently available, like Ancestry DNA or 23andMe. So these are companies and tests that have become increasingly known and utilized in the last few years. So these companies allow individuals to order tests directly from a laboratory, so online or in a store, typically without the input of a healthcare professional or the involvement of a health insurance company. So the customers or the consumers can send that company a DNA sample, like a saliva sample, and then they will receive their results directly from a website or an app or in a written report. And this is in comparison to some other types of genetic testing, like clinic-based genetic testing, where testing is ordered and interpreted and disclosed by a physician or other healthcare professional to the patient. And the federal agency that regulates direct-to-consumer genetic testing is the Food and Drug Administration, the FDA. So that is a general, more broad description. And now I will pass it off to Wynn to provide us with a more detailed background about direct-to-consumer genetic testing.
Thanks, Molly. As I said, I am a member of the Inter-Society Coordinating Committee for Practitioner Education in Genomics, or ISCC-PEG for short, since that's just a really long title. And it's a group that's composed of educators, healthcare providers, including PAs, physicians, pharmacists, and genetic counselors. And this working group created a new resource, which was recently posted on genome.gov, the direct-to-consumer genetic testing FAQ for healthcare professionals. And so we've been meeting in regards to direct-to-consumer genetic testing since 2018. Let's move on to the next slide. Okay, so I like to ask questions, and my goal is always to make people think. So let's start off with the 3 W's that are related to direct-to-consumer genetic testing. We'll start with what. Next slide. So what? We're going to look at concepts related to direct-to-consumer genetic testing. And in medicine, there's an adage I taught all of my students. Never order a test unless you're prepared to deal with the results. It's important to understand what test you order, if the test is appropriate for that patient, and why you're ordering the test. What information are you looking for when we get, or when consumers get direct-to-consumer genetic testing? And do they understand the limitations of the testing? As a genetics provider, my job is to make sure that my patients understand the test being ordered and its limitations. And the first thing is understanding what direct-to-consumer genetic testing is in comparison to other types of genetic tests, and then to explain the components of the testing and make sure that the patients understand concepts like variance and think about medical utility, because you never want to order a test if you're not ready to understand the consequences of the test. Next slide, please. So there are numerous genetic testing models that are out. In our top row, we've got consumer genetic testing, and as you can see, there's really a healthcare provider usually associated with this, and is written consent that is done, but it's done online, and a lot of people will kind of like flip through very quickly. Okay. They scroll down and they click I agree, and they may not necessarily read the entire consent, and it's definitely not explained to them. And then we've got provider-mediated genetic testing, and these are usually consumer initiated, but there are lab companies that employ healthcare providers, and so in this way, consumers can get a little bit more in-depth testing done, and they have a healthcare provider who is provided by the lab company, who helps to discuss some of the ramifications, also what kind of testing will be done, and then the results are reported to the consumer. And then there's clinic-based genetic testing, which is usually ordered by a healthcare professional, and usually ordered because there's some kind of symptom or a concern that a patient has in regards to certain healthcare conditions that might be worrisome or of interest. And oftentimes those are covered by insurance. And then the consent is something that is or should be discussed in depth with the patient themselves, so that they can understand exactly what the test does and will and will not reveal to them. Next slide, please. Okay, so there are different types of healthcare information that direct-to-consumer genetic testing can provide. And perhaps you've already heard about some of these. So things like breast cancer, Parkinson's disease, dementia, macular degeneration, factor V Leiden, which is a type of blood disorder. And there are various carrier or risk variants that people might be concerned about, looking at hyperlipidemia, or also polygenic risk factors for diabetes. So there are a lot of health conditions that can be covered, and you can imagine that these are not benign conditions. These are conditions that people would have some emotion around, right? Even something like macular degeneration, the possibility that you may be losing your vision is not an insignificant one. And that's, what some people might consider relatively minor when you compare it to something like Parkinson's or dementia or cancer. But all of those have effects. And we'll discuss more about this when we talk about the who and the why. Next slide, please. So as I said, one of the things that I think it's important for patients and consumers to understand about is genomic variants. And so in this particular schematic, you've got person one who's got one type of genomic variant, and then person two has a different type of genomic variant. And that's something that I think as human beings understand intuitively that we're all different. But when it comes to testing, it's something that people perhaps don't understand, and perhaps don't understand the ramifications of what these variants may or may not mean when it comes to direct-to-consumer genetic testing. Next slide, please. So if you're a sci-fi fan like me, one of the things that you might realize is that, we're all flawed mutants, although we don't really want to use the word mutation anymore. We use the word variant instead. And as Dr. Francis Collins said, we are all flawed mutants. We all have these quote unquote glitches in our DNA or variations in our DNA. And that 0.4% of variation is all that distinguishes us from other people. And what's important to understand is that some of these quote unquote glitches are significant and others are not. Next slide, please. So we have a number of different categories for variants, and it's important for people to understand how they're categorized. So your variant could be found to be pathogenic, which obviously is something that would be considered responsible for causing the disease. And then at the other end of the spectrum is benign. And so in between, you have kind of these shades of gray where it could be likely pathogenic, it could be a variant of uncertain significance, or it could be likely benign. But what patients and consumers frequently don't understand is that categorization of variants is changing. And so as we do more and more testing, which is a great thing, and we get more and more data, we are understanding more and more about whether the variants that we're finding are either pathogenic or benign, or where they fall in the spectrum. And so if you had testing done 10 years ago, your variant at that time might have been a variant of uncertain significance. However, 10 years, into the future, now we have more data and we are understanding, actually, we know that this is actually more likely to be benign. And so that can be a sigh of relief if it does become characterized as benign, but it could also be characterized as pathogenic. And those are things that people don't understand, is that the field of science is ever changing. There's nothing absolute in medicine except that everything changes. Next slide, please. Okay, so when you have direct-to-consumer genetic testing done, you can get all kinds of fun reports back, and it ranges. You can get non-health related reports and then health related reports. And so the non-health related things could be related to ancestry or different traits. It might show paternity. It could be something recreational like wine preference. It can talk about things like nutrigenomics, which I think people are always interested in, what kind of foods would be better or worse for them, or that they can't tolerate, although I'm always surprised by the people who are, discovering that they can't taste cilantro or that it tastes like soap to them on their genetic test. I think they would have already known that. And longevity. But then on the health related side, things like carrier screening or pharmacogenomics, which is how your genome and genetics can affect your ability to metabolize certain medications. And then risks for hereditary cancer or adult onset diseases. And there are numerous ones depending on which direct-to-consumer genetic testing group that you use. But what I'd like to point out, and next slide, please, is that when you look at an example of the different health predispositions, it's really important to understand, again, the types of variants, but also understand that unfortunately, the variants are based upon a very small slice of diversity in the human genome. And so if you look at the very top line, and that's for BRCA1 and 2, these are genes that everybody's heard of related to breast cancer. And I might have a patient who says that, I got this direct-to-consumer genetic testing done because I'm worried about breast cancer in my family. And it shows that I have none of the variants that are related to BRCA1 and BRCA2. And mistakenly, they may think that I never have to get another mammogram again, which I understand. People don't like getting mammograms, even though they're necessary. But if you look closely, it really only, the direct-to-consumer genetic test really only looks at 3 variants. And there are many, 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 many more variants associated with breast cancer. And it says relevant ethnicities. Now, that's something that people really don't understand, is that the data has to be relevant to your ancestry. And so if your background is not Ashkenazi Jewish, this test has no meaning for you. And so that part can be very difficult and tricky to understand for patients and for consumers. And that's just one example of how these tests can be limiting and misleading for patients, even though it very clearly says on direct consumer genetic tests that you should not use them for making medical decisions, but people who do. Next slide, please. So for patients who have pursued direct-to-consumer genetic testing, as I said, a positive result does not necessarily mean that they're going to go on to develop the health condition. We always have to have additional testing to confirm or really look at the results. And on the opposite end, negative, absent, or undetected, or what may be considered reassuring by the patient's results could be a false negative. So additional testing may actually be needed. And in those cases, it's usually not covered by health insurance. And so what starts out as something fun that was ordered through like Black Friday can end up leading to more and more testing. And so that's one of the reasons why it's important to have your patients and consumers who are making these decisions understand that sometimes it's not one and done. Next slide, please. If there is a health-related result of concern, that has to be confirmed through a CLIA-certified lab. And only if those results have clinical validity and utility and a clinical test available, we use that in conjunction with family history. And they are not, direct-to-consumer genetic tests are not comprehensive. So they should never be used to either reassure a patient that they definitely don't have this condition or won't develop this condition. And in some cases, patients will upload their data to their raw data from direct-to-consumer genetic testing to third-party companies. And frequently, those are incorrect. So that's another thing that people should be aware of. Next slide, please. So the next question was who? So who's affected by direct-to-consumer genetic testing? And Molly's going to be talking about some of the privacy concerns in regards to who owns the data. I'll talk some more about GINA, and Molly's going to talk about the current legislation. And then we'll also talk about, in terms of who is getting tested and who is affected by the testing.
Great, thank you so much for that really excellent overview. And I think as we really think about the what of direct-to-consumer genetic testing and really dive more into the who and the why, we can really see how that does and doesn't intersect with current policy. But first, to take a step back, before I describe more about what policy exists, that's addressing those concerns related to direct-to-consumer genetic testing. I wanted to give a little bit more information in an overview about the National Coordinating Center and our Genetics Policy Hub and the work we do about providing information about genetics policy. So for those who might not be familiar with NCC, we are National Coordinating Center for the Regional Genetics Networks, and we are a program that is federally funded by the Health Resources and Services Administration, HRSA. So NCC, along with the 7 regional genetics networks, which includes a family center that you can see on this map, all work together to achieve the mission of improving access to genetic services for underserved populations. So NCC works to achieve our mission in a variety of ways. Some of those I've highlighted on this slide. So those activities range from genetics and genomics education to improving access to services via telemedicine, or we call it telegenetics, and family engagement partnership is also a really integral part of our system, and engaging those who have genetic conditions, who are at risk for genetic conditions, to really understand what their needs are. And then finally, NCC also has a focus on policy, which is where our genetics policy work comes into play. So this work really began for us a number of years ago with the passage of the Affordable Care Act. So once the Affordable Care Act was passed into law, HRSA, our funders, came to NCC in the regional system to begin to develop specific resources around policy to really help support the delivery of genetic services. So things like genetic testing, genetic counseling, follow-up treatment. So overall, what our system really focuses on is getting access to these services. And we're really looking at that delivery between patient and provider. So in 2015, NCC held a meeting with a group of partners to identify what the policy issues were and what resources are needed to better understand the policy landscape related to the delivery of genetic services. I will note that because we are federally funded, NCC is not positioned to advocate for any certain policies. We don't have a stance or lean in one direction or another for any certain policy. Instead, NCC is really looking at this work through the lens of what policy resources are needed for providers, for public health professionals, for families, to understand what's happening in genetics and how that affects the delivery of care. So in 2017, HRSA specified 2 objectives for NCC to accomplish related to our policy work. And those are to look at monitoring, analyzing, and tracking of national policy issues. And we're also tasked with disseminating information on the practices, policies, and resources related to the genetic service system. So we've been doing this work for a number of years now and have developed multiple resources over that time. And NCC has recently compiled these resources into a new policy website that we were very fortunate to launch last year called the Genetics Policy Hub website. So this is a fully searchable website where you can search for topics and information related to genetics and genetics policy. So things like direct-to-consumer genetic testing, and find everything we have compiled related to that topic. So there's information not just about direct-to-consumer genetic testing, but a wide scope of genetic policy areas as well. So there are a lot of great tools and resources on the website, which I'll go into more detail. So we have policy area pages that summarize different topics and policy concerns that impact the delivery of genetic services. And you can find all the proposed genetics legislation and regulation that we track. And the website also has a Medicaid database, which is updated annually. And through that, we look at all the publicly available written Medicaid policies related to genetic service delivery. And then we also have general resources like events and information about things like this Genetics Policy Hub webinar series. as well as other webinars and other educational events we hold related to policy. So as I mentioned, this is an example of one of the tools on the Genetics Policy Hub website. So this is one of the policy area pages for direct-to-consumer genetic testing. So each page for each policy area is structured similarly. It includes short briefs that describe why a certain topic is a policy concern for the genetics community. It lists the current proposed legislation and regulation related to the topic. And we share policy statements as well from genetics organizations that present on that organization's stance on certain topics, like direct-to-consumer genetic testing. So also on the policy area page, each policy area page is different policy statements. So NCC is tasked with disseminating these statements from organizations working within the genetics community, like national genetics organizations, advocacy organizations, and so forth, that have published positions on certain topics like direct-to-consumer genetic testing. And so we've collated those policy statements together. So on this slide, you can see these are two more recent policy statements about direct-to-consumer genetic testing. So the first on the top is from the American Academy of Family Physicians, and the second is from the National Society of Genetic Counselors. So I know they're a little small, maybe a little hard to read, but to give some of a summary of these two statements, the AAFP statement says that consumers should be informed about the utility of direct-to-consumer genetic testing, about the possibility of inconclusive results, and about the use of consumers' genetic data. And the National Society of Genetics Counselors statement says that consumers should consider the risks of the testing, and these companies should provide counseling or other expertise to help consumers understand the results. And those are just a few of the topics discussed in these two policy statements. So if you're interested, I definitely encourage you to read through them fully. As I mentioned, the Genetics Policy Hub has additional policy statements on direct-to-consumer genetic testing from other genetics organizations as well. So those are also available to learn more about current as well as past policy concerns on this topic. So another tool we have within the Genetics Policy Hub is our tracking of proposed and enacted legislation and regulation at the state and federal level. So we use a system called Physical Note, and we go in every day and look to see what policies and bills are being introduced at the state and the federal level based on specific search terms related to genetics. So we do this with direct-to-consumer genetic testing as well. And this slide lists proposed and enacted legislation related to this policy area. So you can see as of 2023, there are 2 enacted bills at the state level related to direct-to-consumer genetic testing. So they were enacted in Tennessee and Texas. And there's 1 state bill that's currently introduced in Minnesota. And in 2022, 2 bills were enacted in Maryland and Kentucky. And I'll go into more detail about these bills on the next slide. So we also run the Genetics Policy Hub Twitter account, which publishes information about that state and federal legislation that we track. So this is an example of what the graphics on those tweets look like. So we provide the status of the bill, if it's proposed or enacted, the bill number, the title, and relevant information that's within the text of the bill. So this graphic is about Tennessee's Genetic Information Privacy Act, which was enacted in April of this year. So this bill states a direct-to-consumer genetic testing company shall provide to a consumer essential information about the company's collection, use, and disclosure of genetic data, obtain a consumer's initial express consent for collection, use, or disclosure of the consumer's genetic data, require valid legal process for the company's disclosure of a consumer's genetic data to law enforcement or a government entity without the consumer's express written consent, and provide a process for a consumer to access, delete, or destroy their genetic data. So you'll see this is legislation that was enacted in Texas of June this year, and it'll be effective starting in September. And the language is quite similar in this bill compared to the one in Tennessee. So both focus on transparency towards providing consumers information about the use of their genetic data, about obtaining consent related to disclosure of that data. And the bills require companies to have processes in place for a consumer to access or delete or destroy the sample they provided and that data that's associated with it. Again, similarly, this was a bill that was introduced in Minnesota in February. It's not yet enacted. And this would establish requirements, again, related to disclosure and consent of a person's genetic data, which again are similar to the requirements of the bills from Tennessee and Texas that are enacted. And this is an example of two bills that were enacted in 2022 in Maryland and Kentucky. Again, they have placed similar requirements on the direct-to-consumer genetic testing companies. So really the concept of enacting these policies to safeguard the privacy, confidentiality, security, and integrity of a consumer's genetic data is something that's often found in these bills that are related to direct-to-consumer genetic testing. So when we think back to some of those limitations of direct-to-consumer genetic testing and really thinking about that what is direct-to-consumer genetic testing, as well as the policy statements from the AAFP and NSGC, we can see that the policy, again, which is all at the state level, is addressing certain areas of concern related to direct-to-consumer genetic testing. And the bills really all have some similarities to one another and then some differences as well. So along with all this information presented, we've also created a policy brief to give you an overview of what was discussed in this webinar today related to policy. So this is really a snapshot of direct-to-consumer genetic testing policy, as the topic is really constantly evolving, like the genetics field as a whole. So I would encourage you to go into the Genetic Policy Hub website and download the overview if you want to learn more, and to explore those other tools that were mentioned today, those policy area pages, and the legislation that's being tracked. I also briefly mentioned our Medicaid database, which uses publicly available coverage policies to provide information about what genetic services are covered under Medicaid. So Medicaid programs do not currently have specific information about direct-to-consumer genetic testing, as this is something that's done without the involvement of health insurance companies. But the Medicaid database does have information about a variety of other types of genetic testing. So if you're interested, that's a great resource to explore. So with that, I will turn it back over to Wynn to provide us with more of a deep dive into policy perspectives related to direct-to-consumer genetic testing.
Thanks, Molly. That was a great introduction to the Genetics Policy Hub, and it's a really great tool for providers to use. I think that it can be overwhelming, the amount of data that's out there. We're mostly concerned with how do we take the best care of our patients, but ignoring the policy side of the decisions that are being made is not a great way to protect our patients. And so it's helpful to have this great tool to be able to look at and to know that there are people who are keeping an eye out for the different policies that could be affecting our patients. So we're going to move on to, as Molly said, a deeper dive into some policy. And Molly's talked about some state legislation. But what already exists is the Genetic Information Non-Discrimination Act, which was enacted in 2008. And as I said, I like to ask questions. And so we'll start off with a question. I want you all to be thinking about it. Now, obviously, I can't see if you're raising your hand or not, but I want you to be thinking about the question. So GINA, also known as the Genetic Information on Discrimination Act, protects people from discrimination in the following situations. So A, disability insurance, B, healthcare insurance, C, long-term care insurance, D, none of the above, and E, all of the above. So I want you to choose an answer, and obviously there's no rewards for or punishment if you get the answer wrong. Next slide, please. So GINA prohibits health insurers from discrimination based on genetic information. So what the 2008 Act put into law was that genetic information can't be used to determine if someone's eligible for health insurance or to make coverage, underwriting, or premium setting decisions. And health insurers cannot request or require individuals or their family members to undergo genetic testing or to provide any genetic information. So that's helpful. However, we'll move on to the next slide. GINA does not, so as I said, GINA protects people from discrimination in healthcare insurance. However, it does not protect them when it comes to disability insurance or long-term care insurance. And so frequently before my patients get any type of genetic testing done, I will ask them, have you made any purchases in regards to disability insurance or long-term care insurance or life insurance? Because you should do all of those things before you get genetic testing done, because they can affect what happens and what your premiums will be in relation to these other types of insurance. Next slide, please. Okay, next question. GINA protects workers from having genetic information used against them in which of the following instances? So companies of all sizes, the military, and hiring, or D, all of the above. So again, no penalties for wrong answers, but I do want you to think about which of these makes the most sense to you. Next slide, please. So unfortunately, there are exceptions to Title II of GINA. There are health insurance protections for private health insurance, Medicare, Medicaid, the Federal Employee Health Benefits Plan, and the Veterans Health Administration. However, for the U.S. military's TRICARE, GINA offers more limited protection. TRICARE may not use genetic information for coverage, underwriting, or premium setting. However, eligibility for TRICARE is based and contingent upon employment by the U.S. military, and GINA's employment protections do not apply to the U.S. military. In addition, the U.S. Military is permitted to use genetic and medical information to make employment decisions. GINA's health insurance protections also do not cover long-term care insurance, as I said, disability or life insurance, and they only cover companies of a certain size. So if you're below 20, if you work for a company that has less than 25 people, then GINA doesn't apply. Next slide, please. So the answer is it only protects you in hiring. It does not protect you in companies of all sizes, and definitely not in the military. Next slide, please. So going back to the question of who is actually getting direct-to-consumer genetic testing done? And most likely, if you're participating in this webinar, you either have done or you know somebody who has done direct-to-consumer genetic testing. This graph shows that by the start of 2019, more than 26 million consumers had added their DNA to 4 leading commercial ancestry and health databases. And the prediction was, and I believe it holds true, is that within 2 years, there would be more than 100 million users by 2021. And so you can imagine that there is a lot of information out there that people have signed away by signing their consent to these different companies. And so who owns the data? And so you would think if you look at the consent that you own the data because it's your genetic information. But if you look very closely at all of the consents, you actually have consented to give your information to the direct-to-consumer genetic testing companies, and they are allowed to use them for research and also to give that information to other private companies that can do with that data what they would like. Obviously, it needs to be de-identified. However, there's a limit to how much de-identification that can occur with genetic information, unfortunately. And these companies, all these direct-to-consumer genetic testing companies, are companies. They are based on profit margins, and so even though the majority of them are US-owned companies, there's nothing to prevent any country in the world from offering the highest bid that they can get, and then they would own all of that genetic information. And so it's really important for people to understand that when you consent to join these databases, and you think it would be interesting and fun to see, I wonder if I can curl my tongue in a 3-leaf pattern, or if I can metabolize different medications, or if I'm at risk for different health conditions, that some of that information is information that will be shared and has been shared with people that you probably don't realize. And with companies and research institutions. And frequently it is used to help further research. I'm not saying that that's not useful, but I just think it's important for patients and providers and consumers to understand who actually owns the data and consequently who gets affected. So next slide, please. So who's getting tested? Well, as I said, now we've got over 100 million people, so everybody, it seems like, or anybody who's gotten, like a great sale at on Black Friday. But the other thing is, for some special populations are adoptees or people who are conceived using donor egg and sperm, and those may have some different policy considerations. Next slide, please. So if an adoptee is considering direct-to-consumer genetic testing for health information, you can imagine how that would make, it would be difficult, right? Because it's hard to get and often is not available to get any type of family history. And so for adoptees, direct-to-consumer genetic testing may seem like a very attractive option for figuring out things about their health. However, if you're a provider or if you are an adoptee, you should know that testing negative for different disease risk and health results through direct-to-consumer genetic testing, as we've spoken about earlier, has limitations and unfortunately can give adoptees and any consumer of direct-to-consumer genetic testing a false sense of security because they may carry a pathogenic variant that's not included in direct-to-consumer genetic testing. And if they do test positive for a genetic variant that's related to disease, they will still need to have confirmatory testing with clinical genetic testing. And so it's not always great to go fishing for information, even though you can see, as I said, how it can be very attractive for people who don't know their family history. But kinds of medical history might be relevant or appealing to them. Next slide, please. So, if the person considering direct-to-consumer genetic testing was conceived using donor egg or sperm and want to get direct-to-consumer genetic testing to obtain health information, that actually might violate donor agreements for anonymity because, a lot of times ancestry comes up when you are looking for direct-to-consumer genetic testing. Patients can have the option to connect with their donor egg and or sperm bank to inquire about genetic screening that was performed. However, that testing, may be long out of date or it may not have been complete. And so for those patients, they might also consider out-of-pocket clinical genetic testing for further information. But those are special considerations in terms of policy related to different populations that we should think about. Next slide, please. So now we'll jump into the why. What are the ramifications of direct-to-consumer genetic testing? Why is direct-to-consumer genetic testing being performed? Why is it important to consider family history? And then why is it important to understand all the ramifications of direct-to-consumer genetic testing? And people will often use it for long-term planning, but may not consider the effects on their family members. Next slide, please. So there are a lot of benefits for direct-to-consumer genetic testing. It definitely increases people's awareness of genetic conditions. And some of the fear and stigma associated with genetic testing and with discussions about family health history, those can be alleviated with using direct-to-consumer genetic testing because it seems very innocuous. Most of the time, it's really easy. As Molly said, it's a saliva sample or a buccal swab. It's inexpensive. You don't have to worry about getting authorization from your insurance or going to a provider. And especially in our post-COVID world, it's not always easy to find providers. It can be very empowering for people, entertaining, of course, and informative. You can learn about things like ancestry, health, paternity, sports, fitness, and nutrition, and it can be, for some people, a very benign genetic test looking at different benign genetic traits. Next slide, please. But there are definite drawbacks and limitations of direct-to-consumer genetic testing. So the testing and interpretation methods, as I've discussed, can be very limited. They don't test for all the pathogenic variants. And so the results really are not useful for ruling out genetic conditions. Even if there is something that's potentially actionable, they still need to be confirmed. And so that's additional money out of pocket for patients. I'm so sorry. And the results obtained from the test should not be used for diagnosis or to inform any treatment decisions. For ancestry results, some of the limitations and some of the drawbacks for people is that it might reveal genetic relationships to biological relatives that could be unexpected and could possibly be distressing for people. And of course, as we talked about with the Genetics Policy Hub and the state legislation, there's a lot of concerns about privacy and who's using the data. And as I said, the informed consent, unfortunately, is very limited because there's no one available necessarily to explain all the terms to people and to not only explain the terms, but also to explain the ramifications of the terms and to make sure that patients understand things like or have some kind of statistical literacy in understanding risk, because everybody's risk profile and their aversion to risk is different. And so those are all things that are important for people to understand. Next slide, please. And again, there are ramifications on long-term planning and family. So as I said, if you're, depending on your risk profile, there can be ancestry questions that come up that can be confusing for people and, as I said, distressing. If you are the person who gets the testing done, so now you're the gatekeeper of the information, right? You're the one who would tell your siblings or your children, hey, there's this variant that came up on this test that is of concern. And so who decides who gets to keep that information? I mean, it's your information, but that's the thing that with genetic testing, your information and your results also have implications for your siblings and your family members and your children, and maybe revealing of conditions that your parents may have that you may not be aware of. And sometimes the emotional ramifications of testing like this can incite feelings of guilt to say, like, well, I have this variant, I brought this condition on to the family, or to blame, well, this came from, your side of the family. which obviously is definitely not the thought process behind why anybody would want to get direct-to-consumer genetic testing done. But those are all ethical, legal, and social considerations that people need to be thinking about when any type of genetic testing is done. And especially in the cases of direct-to-consumer genetic testing, where there isn't a medical professional or a genetics professional there to help explain the actual implications of the results. Next slide, please. The other thing that people don't understand necessarily is that precision medicine is not only involving the genome, right? And intuitively, we all know, right, that just because we come from a family where X is always true, that your environment is going to change something. So your phenotype, or the person that you are, is informed by both your genome, your genetics, your genotype, but also your lifestyle and your environment. And so in lectures I've done previously, I've got identical twins and pictures of them side by side, and looking at longevity. And in one picture, the woman looks 20 years older than her identical twin, because that person smoked and drank and led a very hard life, didn't wear sunscreen, had a lot of sun exposure. And so you can see how the even identical twins who have identical genomes at birth can take very different paths. And so it's important for people to understand that genetics is not destiny necessarily, and that direct-to-consumer genetic tests do not offer the end-all and be-all answers to all the questions that you're looking for. And that's important for people to understand in terms of, as I said, the implications behind testing and how different variants come into being. Next slide, please. So it's really important to think about family history. And as I said, there are some cases where we're not going to be able to know family history. But even for the people who have genetic testing done, if you really want to have what we call personalized medicine, which is the goal, right, that everybody has medications or care that's very much tailored to their personal genetic profile, it all still has to start with family history, because it's entirely possible to get genetic testing done, but it's important to have the background of family history to inform your medical decision making, because sometimes a variant, again, is very dependent on what does the family history show. And without that, it's not possible to make medical decisions in a vacuum. And we know that family history is really important, and we call it the tool that's it's like our secret weapon, right? Because if you ask about family history, you're going to learn a lot more about people and their medical history than you would if you consider them in a vacuum without asking, do you have a family history of heart disease? And then you find out that, oh, well, not only does this patient of yours who's only in their 40s have a family history of heart disease, but they also have a history of heart disease starting in the early 40s. And so, maybe you will be more vigilant about looking at cholesterol levels, or doing EKGs, or doing stress testing, or asking about symptoms like, are you having chest discomfort or jaw pain or shortness of breath? And that can lead you down the path of really looking more closely. And that is really the key to personalized medicine, is asking a really good family history. Next slide, please. Unfortunately, with family history, they did a CDC study, and as we all know, it's possible to hold two completely divergent and dichotomous thought processes at the same time, right? So, for example, less than 30% of Americans have actively collected health information from their relatives, but 96% of those same people believe that this information is important to know. And so I would encourage all of you, and circumstances change, and the person that would be able to give you health information may not be there in the future. And so it's really important to collect as much health information and family history as you can. And keep in mind that that changes, right, from year to year. So to say one year that you have no family history of heart disease or cancer, and then the next year, two of your uncles and an aunt have been diagnosed with breast cancer or have had a stroke. And so it's really important to make sure that people are asking about family history, asking their family members about it, and then staying updated on it. So that's my last admonition for all of you is hopefully that you will all take that opportunity to gather your family history to understand your own risk and also to help inform whether direct-to-consumer genetic testing is actually right for you or for your patients. And so now I'll turn it back over to Molly.
Great, thank you so much. I think it's really great to think about, to look more at the federal level and think about GINA, to really dive into who is impacted by direct-to-consumer genetic testing and really those benefits and limitations, and how that has ramifications on the population, that's engaging with direct-to-consumer genetic testing, but the population as a whole. And really tying that back into the importance of family health history. So that's really excellent. So thank you. So we have a few minutes left. We can open it up to any questions anyone might have. And while anyone is putting those questions together, just wanted to pull up this final slide that has some contact information, so you can always feel free to email if you have a question that comes up later. And these are some websites that have NCC and the Genetic Policy Hub's resources, as well as our social media. So again, I really encourage you to, look in the Genetics Policy Hub to see the tools that we have compiled. But I also just want to emphasize, that we couldn't do this without all the work and the research of other genetics organizations that also provide a lot of valuable information about direct-to-consumer genetic testing and policy as a whole. All right, not seeing any questions. Maybe we have one question in the chat. So this question says, at Mountain States Regional Genetic Network, we have gotten a number of questions about MTHFR genetic testing, which I believe some individuals get from direct-to-consumer genetic testing. Could you comment on this type of testing? So I don't know if you would have any thoughts on that topic.
I actually don't in terms of whether that's covered by direct-to-consumer genetic testing or not. I do know that when it comes to the questions about specific genes, it's really important, as I said, to get the family history, but also to refer them to a genetics professional. Oftentimes, a genetic counselor is going to be able to give them the best information. And if you go to the National Society of Genetic Counselors website, they have Find a Genetic Counselor resource. And so you can find genetics professionals and clinics that are close to you and that might be helpful for you to be able to find. And so the next question I saw is, does clinical testing also have the information on ancestry and nutrigenomics? Most of the time not, because it's very targeted. And so more likely you're looking for a specific answer to a specific question. And so you have a patient who has X symptoms or, changes on laboratory testing that may be of concern. And so you're looking at either a panel or a single gene testing in some cases where you have a real suspicion this might be related to X, Y, or Z. And so the ancestry and nutrigenomics is not usually a part of that testing. Again, it's very targeted and very dependent on the clinician's background and their ability to look at that particular patient, which again is part of personalized medicine. Looks like somebody's putting together a website. Oh, this is from Christy from Mountain States. Hi, Christy. Yeah, there's a great, I think that that's another great part of NCC is the regional genetics networks. And they have really wonderful resources, a lot of times free CME for providers. All of us is not considered direct-to-consumer genetic testing because there are, it's for research specifically. And so you may get results back, but genetics professionals are or can be involved in the decision-making process, and you can talk to them about results.
Great. So it's 3:00 now. So we will end the webinar, but I just want to say thank you so much to everyone who attended, who asked these questions, and we really appreciate your attendance and your time today. Thank you so much.